Okay. Any questions about the homework? Yeah.
6 through 9, right?
That's what we just did. Chapter 6 through 9. Anybody want me to do anything on the board? Anyone? Okay. Well, just like that. Let's. Is everybody finding online content okay? Any problems at all?
Mine kicked me off. I was like almost done with the homework and it kept flashing, are you sure you wanna go back? Are you sure you wanna go back? And I kept clicking no and it did it again and I didn't see it. And I hit enter and it kicked me off with it.
Oh, do we need to reset something for you?
It was my first attempt.
Oh, okay.
I can still do the second one.
All right.
I just thought it was weird.
So today's chapter 10 through 13. Almost there yet. This is just kind of a little story. Kind of introduction to medication administration. Does that help? Last time I turned them all the way off, I saw a lot of people doing this business. So, medication administration, chapter 10. We have different factors that influence drug doses and action, route of administration, time of administration, age of the client, nutritional status of the client, absorption and excretion of the drug, health status of the client, sex of the client, ethnicity, culture of the client, and genetics. All of these things have effects on how the medications we give patients affect them. Route of administration, if I give a medication IM or IV, will have a different effect or a different half-life also than if I give it by mouth. It also changes the dose we give. We have a medication called metoprolol that we all give patients for rapid heart rates, and we give it in a 50 milligram dose by mouth. We give that same medication 5 milligrams IV for the same dose. Okay, so vice versa, we have medications that we give called for pain called Toradol. We give Toradol IM and IV. IM in the muscle is 60 milligrams. IV is 30 milligrams. But when we give it PO by mouth, we give it like in 5 to 7 milligrams. It's vice versa. So all depending on the route will change how we give the drug. Time of administration, meaning what time we give the patient medication. If I give a patient hydrochlorothiazide at 9 p.m. at night, which is a diuretic, they're going to be up all night peeing, right? And then I can induce falls or something like that. So time of administration is important. Age of the client, it's important to understand that age of the client matters for the fact that it changes how we metabolize the drug. Or if I have a patient that is an older client that has multiple other medications they're taking that can interact with the one medication I'm about to give them, can change things also. Based on a nutritional status will also change how we absorb the medication. Weight has a big thing to do with how we absorb medication. Absorption and excretion of the drug, kidney function, liver function, those kinds of things will change how we manage the drug when we take it. Okay. Health status of the client. a lot of times when I see them in the hospital setting, they've already had some sort of hit to their health. That's why they're admitted. And if they're in the ICU where I see them, then they're really sick, okay? And the health status, meaning if I might be having normal renal function at home or something like that, but the second I get admitted, I might have something else going on that can cause renal issues or other issues that would make me hang on to drugs more or get rid of them quicker. Burns, your metabolism is increased, you get rid of pain medication faster. We have different protocols for pain management for burn patients than we do for regular pain management, because in a burn situation, your body's burning that pain medication a lot quicker. Sex of the client will tell us sometimes what kind of medication we'll give you for blood pressure and those kinds of things. Ethnicity and culture of the client. When I have a Hispanic gentleman that comes in needing blood pressure medication versus a African American person that needs blood pressure medication, we choose two different kinds of medications for the same symptoms, for the same to change their blood pressure because some medications work good for some races and some medications don't when it comes to blood pressure. So that kind of tells us, gives us an idea of what we need to do for our patients. And genetics, obviously, everybody's different. Everybody has their own fingerprint on the world. So not all your patients read your textbooks and react like they're supposed to. So there's 6 rights of safe and accurate medication administration. And this is how it goes. The right patient must receive the right drug in the right amount, by the right route, at the right time, followed by the right documentation. There's a lot of rights in there, okay? All of those are important, and if you follow those, you'll have safe medication administration. Any med error that I've committed, and yes, I know it's hard to believe I'm not perfect, but any medication that I've committed, med error I've committed, I could pick one of these 6 rights that I blew over or didn't pay attention to that made me do a med error. So make sure that you pay attention to that when you start practicing. When it comes to medication administration, patient education is key. We want to tell them both brand and generic names. One time I had a patient come in that was on a medication called Coumadin. Does anybody know what Coumadin is? It's a blood thinner medication. Well, they go to 2 different pharmacies, and one place she had a prescription for Coumadin, and the other place she had a prescription for warfarin, and she was taking both of them. They are both the same medication. One's the trade name, one's the generic name. So that bought her to stay in the hospital when she was bleeding from every little thing. We had to give her some FFP, or fresh frozen plasma, to thicken her back up a little bit, and then watch her INR for a couple days. But yeah, so make sure that you understand the both brand and generic names. Tylenol and acetaminophen. Mm-hmm. We have a very common, they changed the dose of Percocet and Vicodin based on Tylenol overdoses, frequent Tylenol overdoses, because people were not catching on that, hey, Vicodin or Lortab is 5 milligrams of hydrocodone and 500 milligrams of acetaminophen. Well, in the meantime, I can only take it every 4 to 6 hours. Well, I'm going to take some more Tylenol in the meantime. So our patients were unknowingly overdosing themselves on Tylenol. So now Lortab or Vicodin is 5 milligrams of hydrocodone and 325 milligrams of Tylenol to help reduce that possibility of our patients overdosing themselves on Tylenol. I love it when people come to me and ask me questions about medications, because they're like, oh, have you looked at the side effects of Lovenox? It's horrible. Why would I want to take that? And I'm like, oh, have you looked at the side effects of Tylenol? Look at the bottle on Tylenol. And you'll be like, oh, never mind. Everything has a bad ending. So make sure when you're talking to patients that you give them a clear explanation of the amount that they're taking, of when to take the drug, why they're taking the drug, and how they take the drug, okay? Because remember, routes do matter, okay? Here's some routes of medication. We have oral or PO, which is one of the most common that you'll see. Sublingual is under the tongue. Buccal, whatever, how you want to, tomato, however you want to describe that or state that. That's when you put it in the cheek right here. Inside, not you don't stick it to the outside. Parenteral is given IV, or IM is in that class also. Insertion usually is deals with an orifice of some kind. Installation, inhalation, like SVN or like your puffers, albuterol, intranasal, like Flonase or Afrin. And then you have your topical, you have percutaneous and transdermal, okay, and those go just on the skin. We have different equipment that we'll use when it comes to giving medications to patients. When it comes to giving them pills, we'll give them to them in a medicine cup or a souffle cup. The medicine cups that we looked at last week was the blue 30 ml, the clear 30 ml 2 tablespoon cup. Okay, a souffle cup is of the same size, but it's that paper cup that you can crunch up and throw away. We talked about calibrated dropper last week because calibrated droppers are specific to the medication they come with, so make sure you understand that. Oral syringe has a different tip on it than a parenteral syringe that has what we call lure lock, a lure lock on the threads. But we have different ways to give different medications, and some of these are specific to the route that we give them. Let's see here. Here's the medicine cups we were talking about. This is the one you'll see where it has tablespoons and mLs on one side. We don't really see ounces and drams anymore. Here's some of those oral devices we were talking about. This is one of those fancy medicine spoons that you fill up. I don't know if you guys have seen these. If you've had kids or if you remember when you were a kid. And then syringes here. This has a smooth tip. That way you can put it in the corner of the mouth and squirt it in there. Sometimes this is how you sneak the medication in while they're drinking something. You stick it in the corner of their mouth and squirt it while they're swallowing. If you have to. But if you notice something's on here that is specific, is we have markers that tell us exactly how much we're giving our patients. This is what we would call a parenteral syringe. You can attach a needle to it by threading it in there for intramuscular injections or sub-Q injections. Also, when I can thread this needle off and attach it to a needleless system or a lure lock system on the IV, where I can thread it on there and push it in directly into the vein. And this is the needle we were talking about, the lure lock threads that I mentioned. And then the barrel is where the medication is. Make sure that if you do use a syringe that you, the bottom of, not the apex, but the bottom of the plunger is the measurement tool for your line. And that's indicated here by the dotted line. Same thing in 1 ml syringe. You make sure that you understand that sometimes the dosage or the volume that we use will indicate what syringe that we need to use. So if you notice here, of course there's no leading zeros, dang it, but a 1 ml syringe is points, let's look at this really quick. 0.6 would be this line. So then every line after this would be in the hundreds, correct? 0.61, 0.62, 0.63, 0.64, 0.65, okay? Look at the 3 ml syringe. Can I do that same accuracy? No, I can't. I can go 1.1, 1.2, all the way up to, 1.9, but I can't go out to the hundredths. So if I have a medication that requires that amount of accuracy, then I better use the right syringe, right? One of those medications that require that kind of accuracy is insulin. Insulin is measured down in units, and so this would be a 1 ml syringe, but add a 0 to it, so 0.2 would be 20 units, 0.3 would be 30 units, and so on. But insulin has a standard volume and concentration now, so we always use standard insulin syringes to tell us exactly how much we're giving. Okay, so if you notice that even though it's a 1 ml syringe, it's in units, consistent with insulin dosage. So not too many people really like to get stuck with used needles that they've given their patients. I don't know, maybe it's just me. But they came up with safety syringes that have special plastic caps that when you're done, you can put your finger and click it over the end of the needle, so that way it doesn't poke anybody else after it's been used with the patient. Same thing here, this one will go up and it will cover the needle. Needle sticks can be scary. So if you get a needle stick, you have to understand that you get tested that day. You have to go pee, make sure that, and get swabbed and everything, make sure that you're not under any influence other than your own, meaning drugs or alcohol. That way that they can't blame you for having a needle stick, 1. 2, then you get blood tested, and then in 6 months of care later, after you've wondered if you've contracted anything, then you get tested again. In that 6 month time, you take medications like rifampin and Interferon, and a couple other medications that are horrible to take. The side effects are way worse almost than having the disease. And you take that for 6 months while you're waiting to get tested again to see if you've contracted any disease. So it's a horrible. I had a friend who got stuck, and he started and after a week of the medication, he's like, screw this, I can't even live like this. So he stopped taking the medication. Thank goodness his 6 month test came up and he was clear. But who knows, right?
Don't they test the patient too?
They can. It's not a requirement.
Really?
Because it's their own personal privacy. They have to consent for that kind of testing. So yes, hey, I just got stuck and I didn't buy a needle, and I hope you don't have HIV. Do you have HIV? And they can say, that's not your business. And then I can come in and say, well, we're going to test you for it. No, you're not without my consent. So that's patient rights. So you still have to do all the same things either way.
And you don't want to use your finger to cover the end of the needle. You can use another object.
Yeah, you can use another object, or you can. This one shows it here, just pushing the back of that, and it will slides up and it covers it. You don't want to put your finger over the end though. Yes.
So I've never seen one of those safety syringes used. Are they pretty common? Do we use them here in our hospital?
Yes, we do. We do. We have multiple kinds.
There's
I'll go grab some.
a picture on the board, or on the door, I think.
Maybe I just don't remember.
Can I usually watching them? Give me
I usually do, so that's.
it depends if it's intramuscular. I don't not working.
Well, you know.
Yeah, I understand. I think that's one thing.
Striking it too much.
In this class this weekend. He's talking about stuff that I'm like, oh, I need to teach. It's really nice. Yeah.
All right, just went into our storage room here and got us a couple needles we can look at. I'll pass this around. Now don't go poking yourself here. I don't want to have to do any paperwork. So here's one kind of safety device. If you notice, the needle is on the bottom here, And then when I'm done with it, I can just clip this down over the top of it. That's one type of safety device. This one does not have a safety device on it. Not all needles come with safety devices, so this one would be without. Seeing here.
I can't believe you just put that cat back on.
Oh,
But
mine-
the best way to put a cat back on is to do it with, like that, and drop it on the floor. But it's called the scoop method. But usually, I'll be honest with you, I never recap. I usually throw it in the sharps away.
Yeah.
But these are clean needles, so you can pass them around. And then this is one of those safety syringes that you see on the projector right there. This has that little device that makes it so you can put it over the top. But once it's clicked, you can't pull it back, so don't click it. So we'll see. So I'll pass this around. And then this one here, don't blow up yourself, please. This one's what we call a vantage point. So that's a one-time use. It's spring-loaded. So when you use it, you inject your patient, and then if you look closely, when I finish the needle out,
oh, that's cool.
it disappears. The needle disappears into the, if you notice, so you finish this injection, and then you just push a little bit extra, and it all disappears. So if you notice, the needle is now retracted down into the device. So those are what we call vantage points.
That was kind of a clicking noise, but.
Yeah.
I can see it.
Yeah, it was a 30 gauge needle, so it's hard to see from that far away. But you'll have it passed around there. So those are some of the safety syringes. They used to teach us when I very first started, we were starting to go away. We would bend our needles after we would use them. Yeah, but so people were pushing on them and poking themselves because they bend it and they slip or do something dumb. So yeah.
That's kind of hard to believe because you're not, yeah.
Things have changed a lot since, I mean, the way we do CPR and codes and stuff have changed since I started. You know, I've been a nurse now for 8 years. It's like computers, you know, they change every 6 months. So you have an intravenous syringe that is just meaning a larger amount. It still has the same lure lock. You can use a needle or you can hook it up to the IV tubing. But it's a larger volume, so if you notice here, 5 mLs, and it can only go in 0.2 increments. So if I have something that requires something to the hundredths, I'm not going to be using this syringe. And then this is what we were talking about, the needleless syringe system. This is an older version. Here you can inject a needle in here into the port, or you can attach a hub right to the IV tubing and then use your lure lock, okay? So you don't have to keep using needles. So we as nurses and other healthcare providers, unless we're the doctor, we are receiving orders, okay? So we have to understand the medication orders. We have to be able to identify the components of a medication order, okay, the important parts. We have to know the standard abbreviations used in medication administration. Not only do we need to understand the standard abbreviations, but sometimes there's standard abbreviations that are specific to the hospital or facility that we work for. We have to be able to interpret a given medication order, and we have to make sure that we try to use recommended abbreviations as long as not using the ones that JCO, which is accrediting agency for hospitals, we don't use the ones that they say we shouldn't use, okay? So a medication order has multiple parts to it, primarily 7. We have the name of the patient, the name of the drug, the dose of the drug, the route of the drug, the frequency, time, and special instructions related to that, and the date and time when the order was written. And when we had physical paper charts, the signature of the person writing the order. Now, physicians put in their own orders on the computer, and it has an electronic signature that's specific to them. But if you notice, some of those components of the order are specific to patients, the 6 dose rights, the 6 rights of medication administration. But here's an example: cortisporin, otic suspension, 2 drops in the left ear, AU, 3 times a day, at sleep, okay, or at bedtime. So I'll tell you right now, I have never seen AU on an order because the doctors don't remember that either. So they write specifically left ear or right ear because they're like, AU, what? I'll just write it out, left ear. Good. So, yeah, L, they'll put an L circle in the ear more commonly. All parts of the drug order must be stated clearly for accurate, exact interpretation. If you are ever in doubt as to the meaning of any part of a drug order, ask the writer to clarify. That is very important, and that's one of your number 1 job descriptions as a nurse or MA. When you receive an order, you say, I've never given that much medication at one time to a patient. That doesn't look right. You go, hey, did you mean to write? And they're like, oh my gosh, thank goodness you didn't give that. I had a patient I was admitting one time, and he took metoprolol, that medication we were talking about earlier for blood pressure. He took 100 milligrams by mouth every day, extended release. So when they were admitting him, I was watching the NP write the orders, and she put, well, he's NPO, we can't give him anything by mouth, he's going to go on surgery, so we'll just give him all stuff IV. So 100 milligrams metoprolol IV. And I'm like, oh, I'm telling you right now, that's a bad idea. What? Like, I'm looking over your shoulder and you're writing orders, that will be a bad day for that patient. You probably should change that dose. She's like, well, what should I give? I was like, well, kind of like a 10 to 1, so I would say 10 milligrams IV, not 100. She's like, oh my gosh, thank you for catching that, because she's like, I didn't even think about it, and I just wrote it, and I said, yep, and you'll get some nurse that just looks at it and just does it. So when you just write it, make sure you realize that someone will just do it. So it's very important for us to use our critical thinking skills and look at those medications before we give them. Some essential information that's supposed to be on the medical record: dates, medication information, the time of administration, our initials, whether it be electronic or physical initials on a chart, a written chart, and if there's any special instructions, make sure that we look at those. Sometimes they'll have special instructions, or a doctor read a new study that says if you give it this way and try it out. Like we had Lovenox, they were doing a study of Lovenox as a blood thinner medication, kind of like aspirin, that we usually give sub-Q. Well, they were saying that if you give a 70% dose IV and a 30% dose sub-Q, or vice versa, at time of presentation to the ER for chest pain, they were having good results with that. Well, so we'd have to figure, these orders would come through like, who put that? And they're like, oh, it's based on, I just read the study, I promise it's the way to do it. So, all right, you're the boss. So we have to do the math, and it's tiny. If you can imagine, sub-Q is less than an ml. And anyways, so special instructions are important to look at, because if I gave that same dose sub-Q or all IV would change the results for that patient. So here's a view of a written medication administration record. It takes me a second to look at this because we haven't had written at the hospital for a while. We've all transferred everything to electronic. So, but I know some nursing homes and some clinics will still do written medication records.
Isn't that what Obama's pushing for?
Yeah,
2016.
Obamacare said that by 2015.
By the end of 2015.
Yeah, that's what initially it was. So that's part of the reason why a lot of places are trying to get this all wrapped up. But if you notice here, we have the original order date, when it was started, the medication, name, dose, time, and then here we have 12 and 6, because it's Q 6 hours, okay. We also have a route right here, PO, sub-Q, PO, PO. The sub-Q stands for subcutaneous. Well, this just kind of gives you a little bit of an idea. And every facility is different. They have their own way to do things. Even within the same system. Like when I would pick up shifts in Globe, they use Meditech, which is a system that we use here at Mount Graham. But the way the companies work, they're like, you can customize it to be whatever you want it to be. So when I used Meditech and Globe, it was like I was using a completely different system than when I used it here in Stafford. Okay.
Is the common one that you are looking at like on 168? It's computerized.
168. 168. Yes, that's more of a what you'll be looking at. Now it looks pretty confusing, right? They've gotten easier to use since then. When I worked at another hospital, the way that it displayed on the screen sometimes would cause med errors. It could be an issue. But we've changed things up multiple times at the hospital based on feedback. That's a nice thing about having a changeable system. And so ours at the Mount Graham is really easy to follow. So everything is given on a 24-hour clock. We talked about this a little bit last week when I told you about patients getting medications that were meant for 9 p.m. at 9 a.m. because they wrote 9 o'clock. And they're like, well, why'd you give it right then? I meant 9 p.m. Well, if you would have wrote 2100, we would have known better, right? So 24-hour clock's important in medicine administration. So make sure that you understand 24-hour clocks, okay? If you're going into nursing, you're going to have to understand the 24-hour clock. If you want to get some of your answers right on web study, you're going to have to understand the 24-hour clock, okay? This is just a little bit of a reminder for AM times. Everything you just add, drop the colon, add a 0 to the front. That's easy to remember. PM times, just add 12 to it. So 7 p.m. would be 1900, and so on. So when you are reading a medication label, make sure that you look at the generic name and the trade name both, the dosage strength, the form, the route, the total volume, the total amount in the container. Sometimes in the ER, especially when we send patients home with like amoxil or Cipro, PO, or those kinds of things, they come in a powder form, and then we as nurses have to mix it up before we give it to the patient. So there'll be specific directions for mixing or reconstitution, and make sure you look at that, because medication the powder has its own volume, and then we're going to add a certain amount of volume, and then we want a consistent medication concentration at the end so we can predict our dose we're giving our patient. So don't just go willy-nilly going adding water to a container and shaking it up and think, yeah, that looks about right. Because a lot of times they'll tell you 2.1 mLs for this final concentration. So that will change how you administer it. Okay, so make sure that you follow those directions for mixing or reconstitution. And then precautions. A lot of medications we give, if a common side effect is, hey, they're going to stop breathing, or hey, they'll be hypotensive, or hey, this patient will become unconscious. Usually, that's the number one red thing on the label. So we'll say the medication name, and then underneath it we'll say can cause apnea, can cause unconsciousness, can cause drowsiness, right away. So most precautions are on there, or it will specifically say on there, do not give IV. So make sure you look at the labels. And if you look at the label, how many times? 3 times, you'll be safe. So here's a sample medication label. If you notice here, it has highlighted directions for mixing. Add half the total amount. So I would add 14 mLs to get it going, and then I would put another 14 mLs for 29 mLs to get my final concentration of 100 milligrams per 5 mLs. Okay, so that's why you have to make sure that you follow these instructions specifically so you can get this final concentration amount. Okay, because what the doc will order is he might order give 5 mLs. Well, if I don't mix it right, 5 mLs could not be the right dose. So But if you notice, we have the trade name, generic name, route, weight of medication, volume. So all those things are there. Also, something that's specific on labels that you want to make sure you pay attention to is storage instructions. Okay, has to maintain between, if you're going to have it in a suspension form, it needs to be between 36 and 46 degrees, or in a fridge, right? So, but if I just have it unreconstituted or in powder form, I can keep it between 68 and 77 degrees. So that's way better for shelf. Okay.
And the shelf life?
Shelf life is on there, expiration date. Furosemide is the generic name for Lasix. So sometimes you won't have a trade name on there, depending on how long the medication's been out. Furosemide has been out for a very long time, so more than one company produces it now. So you're going to have generic only on the label. Okay. Morphine, very common pain medication that's been out since the 1800s, since everybody's producing their own version of morphine. Most of the time on the label, all it will say is morphine. Okay, but you have a specific drug like Viagra, specific to Pfizer company, so they will have Viagra on the label, and the generic name is sildenafil. So just make sure that you understand that not every time will you have a trade name, but you will always have a generic name. So make sure you understand both.
So in the absence of both, you can assume it's generic.
Yes. But when you start working in the field, you'll looking at it, if it doesn't have a catchy name, you know, it's really easy to say, hey, that's a chemical name, that's an actual name of the medication.
Or if there's that little registered trademark name.
Yeah, if there's a little R next to it. Kefsol, which is cefazolin, okay, or Ancef is another name for it. So here's one that also includes the route, nitrostat or nitroglycerin. Nitroglycerin most of the time won't have a trade name on it like this, but this company, the Park Davis company, has their own name for it, nitrostat, because most of the time when you need nitro, you need a stat, chest pain medication, right? So most of the time you'll just see nitroglycerin though. And it specifically has a route because sublingual is the way that you're supposed to have this, and you put it underneath your tongue when you feed nitro. Here's another medication, lidocaine in 1% solution. We talked about 1%, right? Percent solutions, remember? We talked about dextrose, 5% solution, those kinds of things. So this one is a 1% solution or a 10 milligrams per ml solution. So most of the time, even if they have a 1% solution on there, unless it's a big IV bag, it will tell you exactly what is in there. So I don't have to go do the math for a 1% solution. I can just look on the label and see the concentration of 10 milligrams per ml. Something that's also you need to make sure you understand is if you notice something here, 30 ml multiple dose vial, okay? Based on the vial being able to be used for multi-dose versus single dose, they'll have a different stopper on it, on the top that when you put the needle through, okay? So if it's not made to be a multi-dose vial, don't use it as a multi-dose vial, okay? Because you can, once you break that sterility with a single dose vial, it doesn't reseal very well, and you can get air back in there. You can get other germs back in that that vial that you're using and cause infection for a patient. So unless it's designed to be a multi-dose vial, do not use a single dose vial as a multi-dose vial. Is there any questions about that? Some other things that you might notice on like page 174, there is barcodes now that we put on our patients and barcodes that we put on our medications. And so we started doing this here at Mount Graham about 2 years ago. But before we give a medication to a patient, every bedside now has a computer. And I take my little scanner and I scan my patient's ID band, and then it'll say, yes, your patient's been verified, and then I scan the medication I give, and if it's in ordered, it will say, yes, you can give this medication. If it's not ordered, it'll say, hey, this barcode doesn't match anything on their orders. Go check the orders. Go talk to your physician. It will give you an error message, okay? Something you need to remember, though, is that is only as good as the person who put the orders in, or the person who inputted the barcode. We have fancy machines called Pyxis. These Pyxis machines, you walk up to them and you swipe your badge, and okay, that's your first identifier. And then your second identifier is that it has a fingerprint scanner, and you put your finger on it. So now I'm doubly verified that I can be in this computer. And then it has a fancy patient name list, so I click on the patient name, and then it has only the medications that they are allowed to get. And then I push on the medication. So case in point, I almost had a devastating drug error for a patient. I went in and I clicked on the patient's name, clicked on the medication, phenytoin, which is Dilantin, which is this anti-seizure medication. The patient was there for a hypertensive crisis, and so I went in there to give him his Dilantin seizure medication. So I click on it, phenytoin. The drawer pops out, and it has a ton of drawers, and every drawer has a cap on it. That way you don't go grabbing the wrong drug. The only drug that's available to you will flip up at the top of the lid, so that way you can only grab one medication, right? So that little thing flips up, and I reach down, I get my medication out, right? Because I put my name in there. It's got my fingerprint. I picked the right patient. I picked the right medication. And the only thing available to me is the right drug, right? Wrong answer. So I pick it up, and I go to the bedside, and I look at the label the first time, and it's P-H-E-N-Y, no worry. So I just, real quick glance, I drop the medication. I walk up to the bedside, and P-H-E-N-Y, no worries. I hook it up to the, I'm going to give it IV push, so I hook it up to his IV. And right when I'm about to push it, I look at it one more time. P-H-E-N-Y-L-E-P-H, what? That's not phenytoin. There's no L's in phenytoin, right? It's phenylephrine. Phenylephrine is a medication that we give to hypotensive patients, or patients who have no blood pressure, to constrict their vessels, okay? We give it in a drip form. So I would take one vial and mix it in 250 cc's and hang it for over 24 hours. One vial, and I had 1 vial's worth of phenytoin in my syringe, and I almost gave it all to the patient. To find out, I run back to the drawer. Thank goodness I didn't give it him. Run back to the drawer to look, and the farm tech who stocked the machine, bless her heart, did the same thing I did at first. P-H-E-N-Y, and tossed it in the drawer. Half of them were phenylephrine and half of them were phenytoin. In a drawer, a sealed drawer, that only I should be able to get the right medication, right? So remember that you look at the label 3 times, and that you make sure that you understand that all these safety measures are great, but you still are responsible for your patient safety, because like she didn't plan on restocking with the wrong medication that day. One time I had a medication error where I didn't look at the label 3 times. I hopped in the back of an ambulance, and this young lady had taken too much medications. I might have told you guys this story, but I'll tell it anyways, just to make myself feel better, of course. So, hopped in the back of the ambulance, and she was not breathing for herself very well. We were having to bag her with the bag valve mask. She had taken a lot of medications to try to end her life. And so we decided, hey, we'll just intubate her, make it easy. So, hop in the back of the ambulance. I always do the same routine for medications when we decide to intubate somebody, because that's my safety measure. If I do this, I do this, I do this, I'll do it right every time. And so I gave the patient Sofran, and I always give a pain medication called fentanyl before we do a procedure. So I pull up this vial, and we had two sizes of vial. We had small 2 ml vials for fentanyl, and then we have big 5 ml vials for fentanyl. Well, the 5 mLs were about to expire, so I was like, I'll just use the 5 mLs, which is not my usual routine. So I just reach in my bag, pull out the 5 mLs, look at it really quick, and draw it up and give it to the patient. Okay, so the patient becomes even more sedated, which is fine. We're about to intubate her. I didn't think anything about it, but she starts having a lot of salivary secretions. Like, that's odd. I've never seen that with fentanyl. Didn't think anything of it. Intubated the patient. Procedure went just fine. We were flying throughout the shift, flying throughout the day, the rest of the day with that patient, and I drew up all the medication at one time so I could just, because I knew you don't just give one dose of fentanyl, you give multiple doses of fentanyl after you've had a sedated patient. So I just keep giving this patient the same medication in the same vial because it's not a multi-dose vial, so I pulled it all up in one syringe and was just giving her bumps of the medication. So we get there and deliver the patient, everything's fine, it's good transport. Every once in a while she'd get a little bit hypertensive during the transport, which tells me that she needed a little more pain medication, so I would give her some more pain medication. Didn't even think anything of it. Get back to the base, doing the medication count, because we control our own narcs at Aerovac. We don't have a fancy system other than we count and write and do it all by hand. Like, man, we are off one of our medications. We are low on ketamine. Why are we missing one ketamine? And why are we do we have an extra fentanyl? That's weird. So I'm counting and I count and I count and I go, we are missing a ketamine and we have an extra fentanyl. How's that happening? So I call all the nurses, right? Because it's not me, of course. Call, hey, when you counted this morning, did you notice that we had an extra fentanyl and we were missing a ketamine? They're like, no, that's crazy. And I called everybody because it was obviously everybody else's fault. So we get back, we're at the base, and the medic I was with that day, when we were done intubating the patient in the back of the ambulance and we're loaded in the helicopter, he kind of just grabbed some trash and put it in his pockets, so that way we didn't want to leave their ambulance a complete mess, you know. So we get home and he's starting to empty out his pockets, and he throws out this little tiny lid, the little flap cap lids. I'm like, oh, where'd you get that lid? He's like, oh, that's from the RSI. I'm like, oh, that's the wrong color lid. And he's like, what do you mean? I'm like, that's not what I thought I gave the patient. So we looked to realize I had drawn up a medication called ketamine. Ketamine, thank goodness, is a pain medication and sedative. So I did the math really quick to make sure I didn't overdo it with my patient. And the same ml volume that I was giving was the same dose of ketamine for that patient. So thank goodness I was still giving the right dose to the patient, so I wasn't overdosing the patient. I just gave him the wrong medication. Also, ketamine, if I would have started the procedure and said, you know, hey, let's use ketamine for this, it would have been no big deal, right? Because we can use ketamine for RSI induction and all that kind of stuff. So I could have done ketamine anyways, right? But I didn't know I was giving ketamine, and I thought I was giving fentanyl, and I charted fentanyl the whole time. So is that a med error still? Because it's the right, it's the right medication, right dose, right situation.
You wrote down wrong.
But I did the med error because I thought I was giving something else that time. So I pull out the vials and took a picture of them. They are almost identical vials. They are almost identical colors. It's a light blue versus a royal blue. Okay, same shape, same size. Even says ketamine with red lettering underneath it saying causes sedation, and the fentanyl says fentanyl with red lettering underneath it. So a quick glance, they almost look identical. So it became an issue. I took a picture of it, and it's got circulated. My mistake, of course, got circulated nationwide for Airvat, and several other people came forward and said, hey, that's happened to me too. I just didn't say anything. And also made it so we started ordering different vials. So my medication error ended up being a good thing because it made other people recognize that, hey, those are almost identical. And especially in the dark, in the back of an ambulance, you can grab that in an accident really quick. So it kind of changed how we did things, and the new procedure came out for how we package our ketamine. We have to put tape over it showing that, all extra things so that it doesn't happen again. So med errors, they do happen. Just cross your fingers that nothing ends in patient death, right? My other med error that I had was I didn't hear the order. Patient comes in and he's caught. I walk into the ER and it's all of a sudden hustle and bustle. That's weird. I look over and there's this guy there with a tongue that looks like as big as a filet mignon, and he can't talk because he's having an allergic reaction and his tongue is so big he almost can't breathe. Right? So I run over there like, oh, let's get an IV started. Let's start. You know, I'm helping with this procedure to that way we don't lose an airway and we have an unconscious dead patient. Try to avoid that usually. So, unbeknownst to me, right before I walked up, the doc had given, well, the PA, because the doc was in a critical procedure in the room next door, the PA had given the nurse an order for some epinephrine, which is usual for allergic reaction. So she drew up the epinephrine and handed it to me, says, here, give this. I'm like, oh, all of it? She's like, yeah, all of it. All of it? Really? All of it? She's like, yeah, all of it. I'm like, okay. Gave medication to the patient. So patient starts to come around, tongue's decreasing, he's no longer blue in the face. Still has a big tongue, but at least he's breathing now. And the PA was kind of giving a report off to the doc and telling the doc, you know, like, hey, so this is what we did for this patient. We gave 20 of Pepsid, 125 of Solumet-Medrol, and 0.3 of Epi. I'm like, oh, 0.3? He's like, yeah, 0.3, how much did you give us? I gave a whole milligram. And he could see my face get white, and the doctor was like, oh my gosh. She's like, well, tell the patient to go run around the block a couple times, so I think he'll be okay. But he said, your med air probably saved his life, so we'll let it slide this time. But I didn't hear the order, and the nurse didn't hear the order, so I didn't, but an emergency situation, give it, all of it? All right, cool. You know, I didn't even think twice about it, but that's a med air, right? So make sure that you guys are conscious about what you guys do. You'll notice on here, these look-alike, sound-alike drug errors and things like that. You'll have some sad stories where nurses commit drug errors in patient life, and it's sad. We joke about it now, and I like to have a good time and laugh and tell some of my funny stories so you can learn. But sometimes they're not that funny, unfortunately, and they end in patient harm. So make sure that you're really vigilant in your care, and that you're not one of those people that just gives medications just because it's ordered. Because doctors make errors too, and it's our job to make sure that we understand what we're doing and what we're giving. So, any questions? There's on the homework primarily. It's just going over reading medication labels, and just picking out certain things. They'll say, hey, what's the trade name of this medication? What's the generic name? So let's just go that one more time really quick before I let you go so you can understand what I'm talking about. Maybe.
What page is that?
This is page 199. All right, so what is the trade name of this?
Wait, there is none.
There is no trade name. What is the generic name? Amoxicillin. Let's go to number 2 here. What's the trade name? Vistaril, right? Oh, let's try that again. What is the trade name? Vistaril, right? What is the generic name? Hydroxyzine, right? Okay. Make sure you understand that the trade name's the fancy name, the one that has the trademark next to it, the little R circle, and the generic name is the actual chemical name. So, based on who makes the medication, will tell you that as kind of where the trade name comes from. So you have, case in point, Advil. What's Advil? It's ibuprofen. What is Motrin? Ibuprofen. Those are 2 different trade names for the same generic medication of ibuprofen. Okay, because 2 different companies make it, right?
Same with Aleve.
Aleve, yep. Aleve has a different name too. So, what's the form?
it'd be an injection.
It's injection or intramuscular solution, okay? What's the dosage strength?
50 milligrams per ml.
50 milligrams per ml. Make sure that you understand with dosage strength that you have the weight of the medication and then the volume or vehicle. So it'll be 50 milligrams per ml, 50 milligrams per capsule, 50 milligrams per caplet, 50 milligrams per tablet. You notice I'm emphasizing per, okay, per something, okay? So make sure that you understand that a dosage strength includes two things, the weight and the vehicle, okay? And then your total volume here, what's the total volume of this container? 10 mLs. So you'll see some of these on your homework. Identify these things and just put them in order as they are requested. And every part of this is worth, you have to have every part of it right to get total credit for the question. So make sure that you look closely at it.
That's IMU school.
Yeah, there's multiple. Here's another one. Let's just do this one really quick. That's a hard one to see, but we'll try it. Okay, so what's the trade name of this one?
Cocapine.
Depakote. All right, and it's ER on there. It's hard to see. Might be hard to see for extended release. Okay, what is the generic name? Divalproex sodium. Okay, usually just the medication name is fine. You can just say Divalproex. You don't need to say sodium. Sodium is, they usually attach medications chemically to some sort of electrolyte. That way our body can absorb them. So sodium, magnesium, those kinds of things, you'll see them as part of the name. Sulfate. Sulfate is another ion that they'll attach a medication to. Morphine sulfate, mag sulfate, those kinds of things. That way our body can absorb them. So, but all that really matters is that you understand that there's Divalproex is the generic name. What's the form? Tablets. What's the dosage strength?
250 milligrams per tablet.
Thank you. 250 milligrams per tablet, right? And what's the total amount in the container? 100 tablets. Okay. Any questions about that? All right. You guys have a great week. If you need anything, make sure you swing by my office or see the, yes.
There were a couple of abbreviations that you gave us that were really important ones to know that you don't use anymore.
Oh, from the, it's in your book here. There's a do not use abbreviation list.
I think it's on 156.
Oh,
But there was a couple of them that you gave us that you said they were the ones that we needed to be real careful of.
the microgram.
Microgram is one.
OD
Because if you look on 156 there on the bottom, it has the UG. Unless I wrote that down with the printer, showing that it's that fancy mu symbol. That's what that little M is, mu. I would not know that that is a microgram. I would think that's a milligram, right?
Right.
So though that's one, so that's why I always put MCG instead of the mu symbol for micrograms. Q day is we now write every day. We try to avoid that instead of QID because that's 4 times a day. So we will write every day instead. Can't not remembering any of the other ones I gave you guys that one day.
There's the OD, AU.
Oh, yeah.
Do you want us to use
No, just write it out. If you notice here, kind of error-prone abbreviations, it's on the list there. AD, AU, because AD, AU for eyes would be OD, OU, right? So I wouldn't want to put ear medication in my eyeball, which is kind of bad. Eyes are a little more sensitive than your eardrums.
Maybe one of them was HCL because it surprises me that it's on the list of error prone because it's hydrochloric acid and it's also hydrochloric,
Right.
which is potassium hydrochloride.
So we just every facility you work at will have their own like don't use. So like MS Can be morphine sulfate, can be magnesium sulfate, can be multiple sclerosis.
That's what I was.
So MS is one of those that's avoided. We always write out morphine. Okay. So a lot, like I know in our ICU we have a list on the door on room 2 that says, hey, don't use these medication abbreviations.
So the hospital helps you with
Yeah.
the ones that they know that
Right.
they don't use.
Yeah, error-prone ones that we might see at your facility. So,
Okay.
all right.
Have a great week.